Chapter 7, we will discuss preventive and desensitizing materials. Dental assistants as well as hygienists play important roles in assisting the dentist to prevent disease and maintain the health of our patients. So it is important for us to know the preventive measures that need to be taken to prevent caries, such as the use of fluoride, whether that be in your toothpaste, in a rinse, or the varnishes that we provide in office, antibacterial mouth rinses, as well as sealants for prevention. Fluoride is a naturally occurring mineral. It is effective and safe in preventing decay. However, many of your patients are fearful of it. There have been many studies that say that fluoride can cause problems for patients. There is nothing out there that is evidence-based with enough significant scientific data to back that. But we're never going to fight our patients on that. We can only educate them on what we know, and the rest is kind of up to them because it is their body or their child's body. We always want to make sure that we get their approval for not only placing fluoride varnish on them, but also for their children before we do fluoride. Fluoride can occur naturally, or it can be taken as a supplement. It can be found in well water or in food that has absorbed fluoride from the soil. It can also be an additive, and it is in many of the over-the-counter dental products that are out there. Fluoride is one of the greatest public health successes in the 20th century. Once we started adding fluoride either to our school programs, to water sources, things like that, in safe levels, we decreased the amount of caries in kiddos by large percentages. The accepted optimal level of fluoride in the drinking water is 0.7 milligrams per liter or parts per million. Here are some of the over-the-counter dentifrices that contain fluoride in them now. Kids toothpaste, Biotin fluoride toothpaste for dry mouth, and Sensodyne. Fluoride has been proven to not only help with decay, but it can also help with sensitivity. So you're going to see fluoride out there in just about everything. Fluorosis. We see a lot of fluorosis in our clinic. Many of our patients are natives of Mexico, and in Mexico, there is a high level of naturally occurring fluoride in their water already. So we see lots of fluorosis. We don't see many patients with decay. They've had plenty of fluoride. In fact, they had too much fluoride, which led to the discoloration of their teeth. Mild to moderate fluorosis will just show as opaque white spots or little banding on the teeth, and severe fluorosis is typically 4 times the amount of fluoride that you should receive can lead to this, and with that we see brown staining and pitting of the enamel, which is also sometimes called mottling. Protection against erosion. Erosion is a wearing away of tooth structure due to a chemical. So highly acidic foods can contribute to the loss of tooth mineral. Citrus fruits, sodas, and wine, people that have gastrointestinal reflux disease, people that are bulimic, many times will see acid erosion on the lingual surfaces of their maxillary anterior teeth. Some people will hold lemons or things like that on the front of their teeth, and you'll see erosion all across the anterior teeth on the labial side. With erosion, there's no bacteria involved. This is simply a chemical issue. Most mineral loss is typically seen at the surface, and like I said, the medical conditions that can lead to this are acid reflux, anorexia, and bulimia. Bacterial inhibition occurs when fluoride is used. So fluoride will interfere with the essential enzyme activity of the bacteria. So as bacteria produce their acids that they do while they're metabolizing sugars and starches in the mouth, fluoride that is present in the plaque fluid combine with the hydrogen ions of the acid and become hydrofluoric acid, which will rapidly diffuse those cells and decrease the ability of that bacteria to cause damage. They've proven that fluoride, when we use fluoride combined with chlorhexidine, which is an antimicrobial rinse, this can suppress bacteria that can be associated with dental caries. So we would be using a 0.12% chlorhexidine gluconate solution. Substantivity is how long that material will cling to the teeth and stay in the mouth. So that's kind of like its staying power. Chlorhexidine has a good staying power. Some of the side effects with chlorhexidine are brown staining on the teeth, tongue, and composite restorations, and some patients will complain of a bitter taste. But if we mix this with fluoride, and there's a certain time that they recommend that this is done, I believe it's 1 week a month. I will check on that, but this has been proven to control dental caries in people that are fighting that. Fluoride plus chlorhexidine at a 0.12% equals decreased decay. There are different ways to deliver fluoride to your patients. We can deliver it systemically. Systemically means that it goes into your body. That would be through tablets, drops, and lozenges. The only reason that we would want to deliver fluoride supplements systemically would be if we still had developing teeth under the gum line. So that's going to be for kiddos that still have their primary dentition, that we're concerned maybe they're in an area that has non-fluoridated water and we want to make sure that their teeth are strong. And so we might do drops in their water, tablets, things like that. Once the teeth have formed and developed and erupted into the mouth, we're now going to switch gears to an in-office fluoride application where we place it actually on the tooth, because now we're just trying to prevent decay. The tooth is already formed. We can't do anything more about that, but we can help prevent decay and breakdown of that tooth structure. So we can either use gels or foams or varnish, and we've found that varnish is more effective. Again, it stays. It's got substantivity. We can paint it on the teeth, and it will stay on those teeth for 24 to 48 hours after, sometimes even longer. So we encourage our patients, if we see our patients in the morning, I encourage them not to brush their teeth typically until bedtime. If we see that patient late in the afternoon, I tell them that this is the one and only time that they can forego brushing their teeth tonight and brush the next morning, because we want to leave as much fluoride on those teeth as possible so that we can get the most benefit out of that application. Self-applied topical gels and pastes can be used for people that have chronic decay or people that are trying to prevent decay due to xerostomia, which could be due to cancer treatments, or maybe they're on multiple medications that cause xerostomia. We can use the same trays that we create for bleaching, and they can place fluoride in those and put those on their teeth on a daily basis to help give them the fluoride that they need to keep their teeth protected. Over-the-counter fluoride rinses can be used too. Typically you use about 10 milliliters and swish with it for 30 to 60 seconds. When you use these, you need to wait about 30 minutes to eat or drink so that you give that fluoride a chance to do its job. Again, fluoride-containing toothpaste and prophy pastes are available. We can give our patients prescription toothpaste too that have an even higher fluoride content if they are at a high risk. The biggest thing with fluoride is safety. We always want to use it as directed, and we want to keep it away from small children. The lethal dose of fluoride for children weighing 20 pounds is approximately 700 to 1,500 milligrams of sodium fluoride. if a child sat down and ate one of those little bitty tubes of sparkle toothpaste, it can make them very, very sick. So we want to make sure that we tell parents that you don't want to use these high fluoridated toothpaste with your kids. You don't want to have them swishing with fluoride rinses until they're able to adequately spit things out and not swallow them, because the manufacturers make them taste very, very good. Kiddos will want to drink them. So you want to make sure you keep all of those things out of a child's reach and encourage patients to follow directions as far as how much to use. Pit and fissure sealants are a wonderful preventative measure that we can provide for our patients. 88% of caries in children are found in the pits and fissures and grooves of their chewing teeth or their molars and premolars. So sealants are used to seal any non-carious pits and fissures of deciduous or primary teeth or permanent teeth. So we can seal primary teeth if the grooves are retentive enough. If the primary teeth have very well coalesced grooves, meaning that they're very shallow grooves and they blend well together, then they're probably not going to retain that sealant, and it's probably not worth the effort. If they have deep grooves in their primary teeth, then by all means sealants are a good idea. But remember, we need to etch the enamel of a primary tooth a little bit longer than we would a permanent tooth due to the aprismatic enamel structure. These can come in filled or unfilled, as we talked about in our bonding chapter. They are used to prevent dental caries. They are found primarily on the occlusal surfaces of posterior teeth, but they can be used anywhere there is a groove or a pit that we're concerned about and that we think is deep enough to retain that sealant. There is some thought that if you have a tooth that has carious lesion beginning, that can be sealed over. They think that the caries process is stopped because the food source is no longer available, which can continue that process. There's so many factors that play into that. In our clinic, we do not place sealants over anything that we think is even the start of decay. We would recommend that patient go to their dentist and possibly have a little filling placed, or at least what we called enamelplasty, where the doctor would take a burr and rather than just etching those grooves, would actually go in and sand a little bit away to make sure that decay wasn't blown up underneath that. So if the doctor would go in and kind of just trace those deep grooves with that burr of his handpiece, removing the most conservative amount of tooth structure possible, and everything looked fine, then he would place a sealant over it at that point. If there was decay, he would go ahead and then place a more invasive composite filling to cover and protect that tooth. If a sealant is poorly placed and those margins leak, the caries process can continue. So the worst failure of a sealant is a leaking sealant. Again, not all teeth are going to be good candidates for sealants. We want to consider the age, the oral hygiene, the risk, caries risk of that patient, their diet, fluoride history, and the tooth type and morphology of the tooth. Meaning, we're going to recommend it more for teeth that have steep cuspal inclines or uncoalesced grooves and deep sticky fissures. So if you look at a tooth and it looks like sugar and bacteria and stuff like that, chewy foods could get stuck down in those grooves and lead to decay, they're probably good candidates for sealants. Composition of sealant is similar to composite resin. The resin component is based on a dimethacrylate monomer, that bis-GMA that we talked about. We also mentioned briefly that there is a urethane dimethacrylate, but the bis-GMA is the one that we see and use most often. The polymerization or the curing of that resin material is done through chemical or light cure, and they are typically made of a smaller filler particle because we want them to look nice, and the small fillers will make them more wear resistant than the unfilled sealants. Working time with a sealant, it depends on if it is self-cured, light cured, or dual cured. So a self-cured sealant is going to polymerize to the final set in approximately 2 minutes from the time you mix the sealant. A light cured sealant is typically what you're going to see in today's offices. This gives the operator a little bit more time to work. It gives me time to manipulate the material at will down into those grooves. It requires a 20-second application of the curing light to each tooth or surface to which the material has been applied. However, if you have your overhead light on or your loop light on, it'll start curing by that light as well. Many of the loops come with a shield, or that orange shield that you can pull down over your light on your loops to prevent it from curing as quickly. They come in various colors and they wear differently based on whether they're filled or non-filled. So they can come in a clear material, an amber colored, which is kind of almost an orange. When we did sealants in school sealant programs, when I was in school, we would use these amber colored ones, which I didn't really care for, because when you look in a kiddo's mouth, it's about the color of Cheetos, and so all of their molars have this colored material in them. Now, the reason for that was so that parents could keep an eye on them and let us know if they had fallen out or were no longer present. The clear ones you can't see, and sometimes the tooth-colored ones are hard to see. The opaque ones are more white than the tooth, and I kind of liked those for kids because I could see them, and at least they're white and not orange. These should be examined at each visit for stability, and like I said, if you can point it out to the parents and sometimes even the kiddos so that they can be keeping an eye on those as well. They will wear over time, and if they're unfilled sealants, will wear faster than the ones that have fill. If they're placed properly, wear should not be a big issue. Sealant should not affect a patient's occlusion. We're going to check those with articulating paper after they're placed, and if a patient is hitting super high on one of their sealants, we're going to reduce that. With scalers in our clinic, out in private practice, we would use a round burr and just lightly dust that off until we've taken it out of occlusion so that the patient isn't hitting high on that. So over time, wear isn't really a problem. When we're placing sealants, one of the most important factors is isolation. We want to have a dry field. They do, however, they have come out with sealants that can be placed in a wet environment, which is wonderful. You still need to keep the saliva to a minimum, but at least if there is some moisture in the area, it doesn't completely cause your sealant to fail. There are many steps. We first will take the tooth and clean that surface with pumice. Again, we're not going to use anything that has eugenol or fluoride or anything like that in it because we don't want to affect that bond. So we would do this before we polish our patient for the day and before we do fluoride treatment. We would clean the surfaces of those molar teeth with pumice. Then we're going to rinse really, really well and dry and apply the acid etch, which is phosphoric acid. I think ours is actually 38%, but it can be anywhere from 10 to 38%. I've even seen 42%. So there's quite a range of different percentages. After you have acid etched for about 20 to 30 seconds based on the manufacturer's directions, you will rinse with water thorough, and that will take, you need to probably rinse for 20 to 30 seconds with your high vac so that that acid is not flung onto soft tissue in the throat or mouth. Then we're going to use air and dry that enamel really, really well until it looks frosty. You can use a bonding agent at this point. Some sealants will recommend a bonding agent, and some you'll just place the sealant directly on the tooth. The bonding agent is optional. Some feel like that enhances the retention of the sealant. The sealants that we use in our clinic do not have a bonding agent. We just make sure that we get a really good etch, we keep a dry field, and then we flow that sealant down into those deep grooves. Once you make sure that you have sealant material and it's not placed too heavy or too light, then we're going to kind of drag either an explorer through those grooves to make sure that we've got it in all the grooves we need it, or a micro brush. Then we will use our light to cure that. And again, you want to hold it about 1 millimeter above the sealant for the first couple seconds, and then you can move closer to the sealant. And I think it's typically about a 30-second. Our lights are set. They go through 2 beeps. So you'll know once it's beeped twice, it automatically shuts off, and you have cured it for the recommended amount of time. After you're done with that sealant and you've checked it, then I would remove all of your isolation. If you check it and you have all of your isolation still in place and you have a void or an air bubble or you miss something, you can go ahead and just place a little more sealant material and recure that, and it will bond to the sealant that is there. If you remove all of your isolation material and then check it, it's probably gotten now contaminated with saliva, and you're going to have to re-etch in order to bond more material to the tooth. So I would cure and then check my sealant and then remove my isolation, cotton rolls, parotid pads, all that kind of stuff. And then I would wipe the cured surface of that resin with a cotton roll. You guys may have heard of BPAs that are found in plastics and resins, and how those leach out of water bottles, and if you microwave certain plastics with food in them, you can get BPAs in your food. BPAs can also come out of resins, so if you wipe that oxygen inhibited layer on the top of that sealant, if you're positive that you don't need to bond to that sealant any more material, you can wipe it off, and you decrease that by 95% for your patient. If you need to place more sealant material, you need to leave that oxygen inhibited layer in place, leave your isolation in place, and go ahead and bond directly to that. Some causes for tooth sensitivity. This is probably one of the biggest things you guys will face when you're working out in private practice. So many people experience sensitivity, and it can be for lots of different reasons. If you look at this image, you can see a major cause of tooth sensitivity is root exposure. So recession. We've got recession, and we see where the CEJ is here, and then root is exposed. Our root is not covered with enamel. And many times if we're aggressive brushers, we're brushing the cementum off of that root too. So you've got bare dentin. And when we eat cold, hot, or sweets get up in that area, it can send a zing directly to the nerve. So those exposed dentinal tubules are the cause for that. So the stimulus is going to be the food or fluids or sugars that enter those tubules and are allowed to irritate the pulp of the tooth. So there are desensitizing agents out there on the market, such as Sensodyne, things like that, that we can use to help our patients with that sensitivity. Some of the desensitizing agents, there are 2 main modalities. There are the toothpaste that actually cause occlusion or plugging of those open dentinal tubules, or desensitizing the nerve endings, where it actually goes in and desensitizes the nerves. So if you look at the images here, you can see one of them is showing where the dentinal tubules, the first image on the left is showing where the dentinal tubules run through the dentin, and you can see how the nerves and everything are right under that in the pulp. So that's why when those are wide open, those stimuli just cause havoc. So over on the right image, they've actually used laser desensitization, and you can see how large the tubules were prior to that and then how they've closed after. Some other desensitizing agents are toothpaste, fluoride gels and varnishes, inorganic salt solutions, resin primers, and bonding agents, and sometimes those require curing. Mineralizing agents, so a lot of the toothpaste that are on the market now that are like Enamelon and some of those that contain not only fluoride, but they contain calcium and phosphorus as well, can help with the desensitizing. Glass ionomer surface sealers can be helpful, and then they release that fluoride constantly. And then like that image I showed you, the new laser, they can run the laser over those areas, which causes occlusion of those tubules and kind of calms those nerves down as well. Remineralization is repair of the tooth structure that has been lost. Products such as fluorides, the amorphous calcium phosphates, calcium sodium phosphosilicate, all of these are products that are on the market now. I think one of them is called Remin. I think Sensodyne makes one. Enamelon is one. And so basically by providing these elements in our dentifrice, we're helping to remineralize tooth. Now this can be helpful if we've got incipient areas of decay. If you've got large gross decay, this is not going to remineralize those areas. But if you've got minor areas of breakdown or demineralization, this can be very helpful. The resin infiltration of smooth surface white spot lesions can also aid in remineralization, they've shown. Here are some of the ones I mentioned that you can buy over the counter that contain those remineralizing substances. So in summary, preventative practices in dentistry are so important. We extend far beyond just a cleaning and fluoride now every 6 months. We have many other tools in our box that we can offer or suggest to our patients to help in the prevention of not only decay, but gum disease and things like that. Caries can be arrested, tooth structure can be remineralized, and we can help our patients by performing caries risk assessments and using topical applications of fluoride on a regular basis. Sealants can be used to protect the deep pits and fissures of teeth. If they don't have a filling in them, we don't want them to have a filling in them at any point. We can help prevent that by sealing some of those deep fissures and grooves, even in adult patients. Desensitizing agents are important because people retain their teeth longer, so we're seeing a lot more sensitivity because recession tends to happen as we age, and so therefore we're seeing more sensitive patients.